discovery focuses on in vivo activity, and we have this what's more important: potency, efficacy, activity, or residence time. Um, and the dogma has been potency. You want to give a potent drug because you give less, and therefore your chances of a secondary effect are lower, and so forth. But it started years ago, and I would like to cite Robert Copeland as being a pioneer in this. Bob started to say, but in vivo, real time matters. Concentration never constant, and you'll only get therapy when your drug is on target and it's washing away. It's being absorbed and it's being cleared. So the time that the compound is on there is critical, and you can dissociate that. You can actually have compounds that once they're on board, they bind so tightly that they wash away, but they're still there producing good effect. For example, the angiotensin antihypertensives, some of them lower blood pressure for 24 hours, and you can check and see the compound's gone. There is no presence at all, but they're so tightly bound. So residence time becomes critical. And through his work and others, I think it's appreciated now. That's almost more important than potency. There is a nice article in Nature Reviews, Drug Discovery, and it's in fact entitled that potency is overrated. So that's why I think, and the issue is all our assays are aimed at determining activity. Rightly so. Kinetics was always an afterthought. Okay, we have our main compound. Oh, let's see the offset and onset rates. And it takes extra resources. It takes extra special experiments, ones you would not do to determine activity. And it may seem like wasted time. And I think the ideas that have come out have said no, that is not wasted time. It's essential. You can have two compounds that are equally active, but one has a longer residence time. Well, maybe that's going to separate it and be the one you should go after. So I like the idea that residence time has now entered the first line of testing. I think very important. One more anecdote on that. When we did our HIV entry inhibitor at GSK, Aplaverock, it had pretty crummy PK. It was absorbed rapidly but cleared rapidly. But once it got on the CCR5 receptor, it stayed on. And so what they could do is treat patients, and then 24 hours later, when the drug's gone, and they could pull blood from that patient, they still could not infect it with AIDS because the compound was still there. So it turned what would have been a 4 times a day in terms of ADME drug into a once per day drug. It was really important.